I would like to thank Dr. Goldhaber, Dr. Piazza, and the organizing committee of the North American Thrombosis Forum for inviting me here to speak with you this evening on a topic that's very near and dear to my heart, as Dr. Goldhaber alluded to, that of patient education. And I actually came to the North American Thrombosis Forum last year for the very first time, and I found it extremely interesting. This is a very unique forum that brings healthcare providers, patients, allied health professionals, interested parties into one room to talk about the same thing. We have common goals, and I really found that to be a very interesting concept. And so I think this is a perfect forum to talk about patient education. So what exactly is patient education? Well, both the Joint Commission and the World Health Organization have definitions for them, and I think they're very important and very succinct. The Joint Commission states patient education is to improve patient health outcomes by promoting healthy behavior and involving the patient in care and care decisions. So this whole concept of making the patient really, truly an advocate in their own management. And the World Health Organization says that any combination of planned activities leading to a situation in which people want to be healthy, know how to obtain health, and do what they can individually and collectively and seek help when needed. So you can really see the overlap of these two concepts. Well, what are the goals of patient education? Obviously, improve patient participation and compliance. A patient that is actively participating in their care can have better outcomes. One of the earlier speakers talked about therapeutic time and range for anticoagulation. And why was that? That was probably a patient that was actively engaged in their care, had their INRs tested when they were supposed to, and followed the rules. So the patient kind of assumes maximum responsibility for their care, thereby improving their overall outcomes, as well as satisfaction of how they're feeling and generalized quality of life for them. Effective utilization of resources as well. There are multiple resources out there for patient education. Okay, there are organizations, scientific organizations that create educational materials, hospitals, pharmaceutical companies, device companies. There's certainly not a lack of educational resources for patients. Oftentimes it's getting those resources to the patient that's important. And that's where I feel that we as healthcare providers and the patients themselves being active advocates and being able to access these data. Improved quality of care, again, this is all kind of coming together. Patient satisfaction, quality of care, having patients that are better educated. And lastly, reducing healthcare costs. In an era where we're trying to reduce costs, I think patient education is a very important piece of this. We're going to be actively involved in moving away for this pay per service to more of a bundled payment system. And the real impetus is going to be on keeping patients out of the hospital. Okay, this is where reimbursement's going to come in. So being able to keep patients out of the hospital, how do we do that? Making patients better advocates in their own care. So you've seen some of these statistics already, that more than 2.2 million individuals in the United States have atrial fibrillation. That's a staggering number. But what is more staggering is that as the population ages, so as the baby boomers are kind of, those of us born in kind of the late 1950s, 1960s, as we start to come into the later stages in our life, we're going to see the prevalence of atrial fibrillation increase. So we're going to have more people that are living longer. So it's estimated that we may have 12, even up to 16 million individuals living with atrial fibrillation by the year 2050. And as AF increases, the risk of ischemic stroke increases about 5-fold. Atrial fibrillation accounts for about 36% of strokes in individuals age 80 to 89 years old. So again, as we're seeing, these patients are living longer, but we're seeing consequences associated with that. And strokes associated with atrial fibrillation tend to be more disabling than those patients who have strokes from other sources. So what is the definition of a stroke? Okay, so for those clinicians in the room, we're all pretty familiar with what this warning signs are for patients who may be having a stroke. There are two specific types. Ischemic, so that's typically clot-related, where the patient has an embolism. I always explain to patients when you're in atrial fibrillation, the atria, instead of contracting and relaxing, the atria are basically just quivering, and they're not pumping blood and emptying the atria fully. So blood can pool in the atria, and blood clots can form. And if a piece of that were to break loose, it goes generally directly up to the brain, where you get a disruption of blood flow. The second is hemorrhagic, where we actually see bleeding into the brain. And as we've been talking a lot about these novel anticoagulants, these are what we are seeing with it, that there's a reduction in hemorrhagic stroke associated with these medications. And this is just a cartoon kind of illustrating to you. It shows, it's pretty clear where on the patient's left-hand side, so the right-hand side of your screen, you can see that there's plaque there and a patient has a clot lodged in there, and kind of downstream or upstream, if you think about it, there's no blood flow and there's brain death. So what are the warning signs for stroke? We think about the acronym FAST. And as I mentioned earlier, as healthcare providers, this is something we learn very early on in our careers, okay? We hear the word chest pain, we think myocardial infarction or heart attack, and we always default to that. We think of facial drooping or slurred speech, we automatically think stroke, okay? These are emergency medical conditions. So it's important for patients and the public in general to have an understanding of what the warning signs are, because they can be subtle, okay? Not being able to pick up your fork to eat, just something as simple as that. Changes in neurological function that can be very subtle, but may be indicative of something happening. People are pretty familiar with the facial droop, but other things such as numbness in the face or drooling from one side. The arms, where you can have sudden numbness or even paralysis on one side of the body. Patient may have trouble walking. So these are warning signs that you should be aware of. So that's the FA, part of FAST. The S refers to speech. So the patient may actually have trouble speaking, may have trouble understanding speech, may not make any sense that they are up there thinking they're having a salient conversation with you and they're talking ragtime. You have no idea, or they have no idea that they're not making any sense. And lastly is time, okay? It's critical to get these patients to definitive therapy as quickly as possible. So time lost is brain loss. This is an emergency condition, so don't wait to call 911. So what are some of the risk factors for stroke and atrial fibrillation? Well, there are obviously very strong predictors if the patient has had a stroke or a transient ischemic attack, so kind of a precursor to stroke in the past. Those patients that have prosthetic heart valves or mitral stenosis. And then moderate concerns would be at age greater than 75 years, hypertension, diabetes, these things that you've seen in the CHAD scale that we're going to talk a little bit about in a minute, and we've already gone over a little bit, but these modifiable risk factors in patients. There's limited data on patients aged 65 to 75 years. We've talked about females already, that they may have a slightly higher risk of stroke than males. And again, coronary artery disease or thyrotoxicosis. And unproven AF duration. We've always kind of thought about the window of opportunity, so that when a patient goes into atrial fibrillation, we typically give them a 24-hour window before we need to either get them cardioverted or start them on anticoagulation. But again, that's kind of a nebulous time duration. Paroxysmal atrial fibrillation, it is thought that the conversion back to sinus rhythm, so that when the patient's been fibrillating, it's that conversion back to sinus rhythm, which is when their greatest risk of having an embolic stroke may be. And left atrial size, the larger diameter of the atrium, also contributes to, or potentially contributes to, stroke risk. So you've seen this several times in several presentations tonight. This is the CHAD score. And again, this looks at some modifiable risk factors associated with atrial fibrillation. And we I work in arrhythmia management, so in taking care of patients on a daily basis, we use the CHAD score and the CHADS-VASc score every day in managing patients. And interestingly, I had a patient come into the office yesterday who has a pacemaker in, and the pacemaker is actually very nice to have because it provides us with diagnostic information about what the patient's heart rhythm's been doing since the last time we saw them. And this woman, when I interrogated her device, I could see very clearly her episodes of paroxysmal atrial fibrillation. And it dated back to 2009 when she had her device implanted. And I could see over time that she was having more atrial fibrillation, and the episodes were lasting a little bit longer. Sometimes, up to 6 hours, but certainly not up to the 24-hour mark. Well, if we took the CHAD score back in 2009 when we first started looking at these data, we said, all right, she was 65 at the time. No, she was actually 67 at the time. She had hypertension, and that was it. So we put her on an aspirin. Okay, it made sense according to the CHAD score at that time. However, if we move on to the CHADS VAS score, which is pretty much predominantly what we use in the clinic setting nowadays for managing patients, if we now look at the CHADS VAS score, okay, so she's got hypertension, that gives her 1 point. She's now 70 years old, so that gives her another point. And she's female. That gives her 3 points. So if you remember back to the slide that Dr. Goldhaber showed earlier, that a point of 3 on the CHADS VAS score gives her about a 2.2% per year risk of stroke. So when we saw this woman in clinic yesterday, saw that she was still having recurrent episodes of paroxysmal atrial fibrillation and now had a CHADS VAS score of 3, we switched her over to, or decided to take her off the aspirin and switch her to an anticoagulant. But then came the question, well, which anticoagulant do we use? Okay, and this is something that we as healthcare professionals haven't really sorted out yet, in what patient population do we use which particular drug. And as Dr. Ruff mentioned, it's very important to have a one-on-one conversation with the patient. You need to provide the pros and cons of each approach. So talking to them about Coumadin, that, with Coumadin, it does have a slow onset and a slow offset, but that's actually a good thing because if the patient does miss some doses, at least they are protected during that time. Whereas if you're giving them one of these novel anticoagulants, you're going to have an offset in, less than 24 hours or so. So it's important that cost is a very important thing. These novel anticoagulants do cost more than Coumadin, so that is a factor for the patient, although it's getting a little bit easier with the insurance coverage nowadays. We talk about reversal agents. For the vitamin K antagonist Coumadin, there's reversal agent, but for the other novel anticoagulants, we don't really have anything that's been proven. We talked a little bit about prothrombin complex concentrate. There was an animal study that looked at that. It did reduce bleeding, but again, application to humans, on a large scale. And I know this is a big concern for a lot of emergency physicians. Some of the other drugs, the rivaroxaban, using anti-10A agents for that, or if the drug has been given in not too distant proximity to the time the patient arrives in the emergency room, using activated charcoal to try to reverse the effect of the medication. So it's important to have these conversations with these patients so that they can make an educated decision. They need to be an active participant in their care. They need to understand the consequences of it. And again, I feel, and it goes along with the slide that Dr. Goldhaber showed, that many patients are still undertreated from an anticoagulant perspective. So this woman was given the choice between Coumadin and Pradaxa. Her husband was on Coumadin for a pulmonary embolism, so she was quite familiar with how Coumadin was used. They had a home INR, monitor to check it at home. But she was interested in the newer drugs that didn't require the testing. So we gave her a prescription for Pradaxa. She went home. She was going to talk to her primary care doctor to get his take on the whole thing. So the CHADS VAS score does play a very important role in how we manage our patients on a day-to-day basis. And I'm not going to spend too much time talking about, you've seen these slides already. Warfarin still is really the gold standard for managing anticoagulation in patients with atrial fibrillation. Again, looking at the line of unity here, you can see pretty much across the board, this is warfarin, favoring warfarin on this side of the line of unity as compared to other treatment strategies, that one being placebo. We've talked a little bit about the RELY trial already. Again, you've seen these data. Again, looking at the line of unity, if I can get my mouse going here. Pretty much for the most part, it favored dabigatran, but we did see a reduction in intracranial hemorrhage as compared to warfarin, but did see an increase in major GI bleeding. We have been using Pradaxa pretty frequently in our practice. I've had one patient personally I've had to take off for GI bleeding during that time. Xarelto or rivaroxaban, this was the ROCKET AF trial. Again, you can see Xarelto compared to warfarin. Just trying to get my mouse up here. So here is the Xarelto, here is the warfarin, here this is the cumulative event rate. And you can see, as was shown in prior studies, that in the intention to treat group, that there was no real significance difference in the comparison between the two. So this is showing the guidelines from back in 2006. Looking again, this was utilizing the CHAD score, not the CHADS-VAS score, looking at dosing with aspirin versus warfarin. And as was brought up by Dr. Ruff earlier, that the new guidelines from 2011 did include dabigatran or Pradaxa as a useful alternative to warfarin for the prevention of stroke and systemic embolism, these patients with non-valvular atrial fibrillation. So what are some of the future directions of patient education? And I think that my biggest point that I want to get across tonight, and I think this forum is a great venue for that, is to improve awareness. Making patients aware of what is atrial fibrillation, what are the consequences of atrial fibrillation, what they can do for risk modification, and how they can best advocate for themselves. There are many different venues for education. The internet is a great venue. My mom, who's 90 years old, has atrial fibrillation. She is on Tikecin, she is on Xarelto, she's been on Coumadin, she's been on Pradaxa, now she's on Xarelto. She gets on the internet every day, she's researching things. So a lot of people discount that as an educational tool for the elderly, but in fact, many more elderly folks are using the internet. Health resource centers. At the Brigham, we have the Cardiac Wellness Center, and there are similar things across the U.S. that many hospitals have, places where patients can go to get education about atrial fibrillation. Video conferencing and WebExing. And as Dr. Goldhaber alluded to, I ran a very successful atrial fibrillation program for patients starting back in 1999. At times we would have up close to 800 patients and family members that would fill a conference room at the Westin Copley Place. However, as resources are getting tighter and getting funding for such programs has been getting a little bit more challenging, we need to think about different ways to get the word out to people. And using web conferencing or WebEx, where patients can actually log on from home and be able to interact with experts, be able to send their questions in. This is something as healthcare professionals that we use all the time for education. So we're going to probably see more of this popping up in the future. Outreach programs and social media has also begun to play an important role in education. Now, the Heart Rhythm Society, of which is our scientific organization for individuals like myself who take care of patients with heart rhythm disorders, and I actually got nominated to their board of trustees recently because I'm very excited to be working with them in a little bit more in depth. But the Heart Rhythm Society really advocates for patient awareness. And back in July of last year, the Heart Rhythm Society actually partnered with a Republican senator from Idaho, and they introduced the AF resolution bill before the Senate. The resolution, I'm just going to read through this, it promoted increased awareness, diagnosis, and treatment of atrial fibrillation to address the high morbidity and mortality rates and to prevent avoidable hospitalizations associated with the disease. On the same day, the Senate passed the AF resolution. It was kind of a no-brainer. Okay, this is a very important initiative. And September has now been made National Atrial Fibrillation Awareness Month. And this website that I put up here, myaf.afib.org, is a great resource, again, for both clinicians and patients alike. And I don't know if we're going to have time to chat in the panel discussion a little bit. I'll just make mention of it that the Heart Rhythm Society actually has their 33rd annual scientific session here in Boston next month. It's going to be May 9th through the 12th. And the Heart Rhythm Society is going to be running a lot of patient awareness campaigns around the meeting. I think it's going to start on the 5th, and Governor Deval Patrick has actually made May the Arrhythmia Awareness Month for the Commonwealth of Massachusetts. Mayor Menino has made May 9th Arrhythmia Day for the city of Boston. So for those patients that are in the room, if you're interested, there will be public service announcements on the radio. There will be in the calendars, the newspaper, if you're interested in participating in one of these AF awareness events. There's actually, Spectranetics has a huge van, an education van that's coming to Boston. It'll be at City Hall. It'll probably be at Boston City Hospital. So this is going to be all around the Boston area, kind of during that second week in May. And just a couple of the things I wanted to make mention of. There is also what's known as the Arrhythmia Alliance. This was a group that's out of the UK. And this was actually started by a mom whose daughter had neurocardiogenic syncope, which was a benign fainting condition. But back when her daughter, who's now 20, when she was young, she developed this condition, there was no information for her about what neurocardiogenic syncope was. So she started this foundation, the Arrhythmia Alliance in the UK. It's now become kind of an international group. Sir Roger Moore, who actually has bradycardia, had a pacemaker put in, is an active advocate for the Arrhythmia Alliance. I know he got his Sir. Roger Moore, wasn't he the James Bond guy? Yeah, exactly. So he's become a big advocate for arrhythmias, and they have this campaign about Know Your Pulse. And you can actually see they have a iPhone download so that patients can learn how to check their pulse. And this is an important thing that's often overlooked, teaching patients how to check their pulse. I mean, it's a very simple thing, but when you think about it, what's the first thing that we do as healthcare providers when patients come into the office, come into the emergency room? We check their vital signs. We check their pulse. We check their blood pressure. And just to go off on another little tangent, because I'm known for that, my daughter has had a vestibular migraine going on for about 6 months now and has a lot of dysautonomia associated with it. And I took her to her neurologist at Mass General, and he did a very in-depth evaluation of her orthostatic vital signs and noticed how the quality of her heart rate changed, the intensity of her pulse changed when she went from a sitting to a lying position. So the pulse gives us a lot of important information, and I think it's something that is very overlooked, and it's a very simple thing to teach patients how to check their pulse, to know when it's irregular. And obviously we don't want a bunch of neurotic patients running around checking their pulse all the time, but it's an important piece that patients understand how to do this. So there's other available tools for them to know how to do that. Lifeline screening, many of you may have heard of these, where patients can actually pay to go in to be evaluated. They can pay to have a cardiac echocardiogram done, or carotid screening. And again, I feel like it's a little bit controversial, but I think their intent is good, that they're trying to promote awareness, they're trying to identify early problems before a problem. And lastly, kind of finishing up, I know, Facebook, Twitter, these are things that your kids probably, are on their iPhone all the time. on Facebook, these have become very important tools for relaying information. In fact, the American Heart Association has a Facebook page. The Heart Rhythm Society has a Facebook page. The Brigham and Women's Hospital has a Facebook page. And it's a way of being able to communicate awareness about atrial fibrillation and provide education for patients or information about how to get more education about it. So in conclusion, and again, I kind of echo what Dr. Goldhaber said, that strokes can be preventable, okay, by identifying at-risk patients, being able to educate them about risk modification, so better control of their diabetes, better control of the hypertension, and being able to reduce their risk is important. And we, whether you're a physician, whether you're an allied healthcare professional, whether you're a patient, we all play a role in educating ourselves and others about atrial fibrillation and the potential consequences associated with it. Understanding the acronym FAST, and I think, again, being an advocate for education, and just, kind of to echo what the JCO definition of that is about improving patient outcomes, and again, improving quality of life, and that's what I think that we're all here for, is for our patients and to improve their overall experience. So thank you for your time.
That's great.
Thank you.